introduce the next speaker, Dr. Farook Mirza. Do I pronounce it correct, Doctor?
Yeah, you did. Yeah.
He's from Canada. Welcome and thanks for taking the time to share with us Leadership WalkRound for Patient Safety. Welcome, and you can start the presentation and share with us. Thank you.
Thank you so much. Thank you so much for your introduction, Dr. Telly. And can you hear me well? Can everyone hear me well?
Oh, you can.
Am I audible? Okay, that's fine. I thank you, Dr. Telly, for the introduction, and I also thank the organizing committee of the Utilitarian Conference Group, and especially Dr. Pascal for giving me the opportunity to speak here. And it's a lovely opportunity to share our views with the global colleagues and share a wide spectrum of issues regarding healthcare. And so let me get started with my presentation. And can everybody hear me well? Is that perfectly okay? Okay. Yeah. I will be speaking about patient safety leadership walk-rounds. I have nothing, this is my disclosure. I have nothing to disclose, and I do not have any financial or any commercial interest in any of the information I am sharing in this presentation. Am I audible? Am I okay? The journey of this presentation will include about things about evolution of WalkRounds as a voice for frontline staff. It will be about leadership WalkRounds as a patient safety tool. And then we will discuss the scheduling process, the preparation process, participation, interaction, and action plans. And later on, we'll go to data collection, analysis of data, trending, and interpretation. And finally, we will discuss about action plan implementation and the closure of the loop. I would spend some time on this closure of the loop. We always need to close the loop on the actions we should plan, because unless the loop is closed, the actions are either undone or in progress, so they don't actually, they are not completed. And as part of my presentation, I will be sharing with you some of the videos about patient safety walk-rounds and about critical language and safety culture. Basically, leadership walk-rounds is all about safety culture. We have to have a proper safe culture within the organization, which will enable us to deliver quality and patient safety care to our patients. This tool was introduced by Institute of Healthcare Improvement. As you can see, this is the website of Institute of Healthcare Improvement, way back in 1997. It was a very nice tool, and immediately it got picked up by the organizations all over the world. And immediately the Joint Commission picked up the tool and approved it for use by the hospitals, and it was used rapidly all around the world. And now I want to discuss something here. Can you see a pair of shoes here? You can see a pair of shoes here on my slide. I'm sorry to put a pair of shoes here, but I have to communicate something through this pair of shoes. When leaders move more and more in the areas of patient care, I mean, they walk around in the patient's areas of patient care, in the wards, in the ICU, in the outpatient department, in the emergency department. That's the best way to link what we discuss in the boardroom as strategies and what we implement on the bedside for improving patient safety. And that's how, when what we discuss in the boardroom and develop strategies, and then we go to the bedside and we check whether those strategies have been either rolled out or in progress or have been completed. And this is another thing which I want to emphasize with you, with all of you. When the leaders interact with the frontline staff, the leaders really disclose a lot of unfiltered truth. What do I mean by this is that there are always things which are hidden under the cracks. And when we go out there, when we open the cracks, there you will definitely find so many issues with the nurses, with the resident doctors, with the technicians, with the pharmacists, which they have never been able to come up, bring up to their supervisors or their heads of departments. But when leaders go there and they talk to them, they gain their confidence, and frontline workers answer their questions, they feel safe, they speak up. That is why this interaction really brings about a lot of things which are hidden below the cracks. I really love this. Love few of these quotes from a CEO named Mike Sherrod. He's the CEO of Springview Hospital in Georgia. What he has said, that rounding has been a key to his success as a CEO. I mean, he has said that how can leadership understand the needs of physicians, patients, and nurses without interacting with them? A resident or a resident physician or a staff nurse or a technician or a pharmacist or a physiotherapist hardly ever gets a chance to talk to the CEO. But this tool helps them to directly have the confidence to talk to the person who is leading the organization. And he has also said that rounding takes me beyond the paper dashboard and brings me close to the organization at the ground level, and he can really feel the true pulse of the organization. And it also demonstrates that patient safety is highlighted as an important organizational tool, and this walk-around can do a better job than we have the conventional newsletters, staff meetings, and posters and campaigns, because this generates a true interaction between the heart and soul of leadership to the heart and soul of the frontline staff. And I like this concept of linking boardroom strategies with bedside actions. Whatever is discussed in the boardroom, sometimes it gets lost either in the middle management or it gets lost at the floor. But when leadership discusses something, involves the middle managers are levers of change. Whatever they discuss in the boardroom, they filter it out and they discuss it, and then they are levers of change, and they ensure that things are completed at the front line. Unless there is a link between these two strategies, we may not be able to close the loop on many of our actions, strategies which we plan in the boardroom. Now I'm going to share, as part of my presentation, I would like to share a video about the significance of leadership walk-rounds, because this is a tool. This is, in my experience as a patient safety professional, I think this has a lot of potential to improve patient safety. And so that's why I'm planning to show a video and to demonstrate its significance in patient safety. This video will take about 2.5 to 3 minutes time, and I would like the audience to focus on this video, and then we can have a short discussion about the video.
Dr. Farook, are you having any challenges with regard to your presentation, to the video? Dr. Farook?
Yes?
There's no video showing.
It's not sharing?
No.
Is it okay now?
Yes. Now it's showing.
Oh, can I restart it? I will restart it.
But there's no sound.
Oh, really? Is it okay?
No audio, no sound.
Oh, what's happening? I don't know. Let me restart it. Is it okay?
There's still no sound.
Is it okay?
Still no sound, Doctor.
Is there? I'm trying to fix it. Is there any problem?
We still have no sound.
Oh my God. Is it okay?
Now it's no longer sharing, and yeah, no sound, no longer sharing. Still no sound. Sharing, but no sound.
I don't know what's happening. I'm sorry. I'm trying to figure it out.
Okay. Maybe
I'm trying to
continue
figure-
and then later you can share with us the video.
Yeah.
An example I saw was when the board chair became the chair of quality and safety. It's a way of affirming this is the most important.
Every video brings to the brand what you're passionate about. People don't. I do hope that my staff know the quality of patient
Dr. Farook,
Yes.
if you look in the toolbar on top of the video, there's an audio button there. Maybe you should click, that's it. That will bring the sound, I think.
This one?
Yeah, click on it or something.
I clicked on it already.
Doesn't want to work.
I don't know what's happening. Let me try something here. There's another tool here. Let me try to fix it. Microphone is connected. Speakers connected. Audio control. Let me try to fix something. It's full. It's full. Let me try to see here. Let me try. I tried something here.
Could I ask Dr. Farook, are you actually wearing an earphone to pick up the sound?
Yeah, I'm wearing an earphone. Yeah.
Is that a medical necessity?
No.
Right. It's just that may well be picking up the volume, the sound,
Okay.
and stopping it going to the rest of the group, the audience.
I don't know because I have to hear you. Otherwise, I won't be able to hear you.
Well, the thing is, if you're able, I do not know. I mean, I'm not a techie, but it's a guess that maybe that is.
I don't know.
Yeah.
No, it's not a medical necessity because I can't hear you otherwise.
Dr.
Okay.
Farook,
Yes.
can I make a suggestion?
Yes.
Can you continue with the presentation and then when at the end we try the video again?
Okay. Thank
Is
you.
there some more of the presentation?
Of course.
Yeah, we can try the video later again.
Yeah. Let's try the video. I'm sorry. I don't know. There's a technical glitch. I don't know what happened. Okay. Shall we move?
Yes, please.
Okay. And what are the objectives of our walk rounds? Is that
Do the presentation, get out of the video link.
Yeah, I think I am already out of it.
We're
I'm
still
all-
seeing that.
I'm out of it now. Let me go to video. Okay. Can you see my presentation now?
That's it. Thank you.
Okay. All right. Thank you so much. I'm sorry for the technical glitch. I don't know what happened.
No, it's not a problem.
I tried it yesterday. It was working. I don't know. I tried whatever tools I had here, but it seems there's some problem. Okay. Objectives of our leadership walk-rounds is that it establishes a transparent communication between leaders and the frontline staff. And the frontline staff gain the confidence needed to speak up about the problems they face with day-to-day workflow. And also leadership walk-rounds have been known to be a catalyst for reporting of safety events to establish a culture of safety. And reporting of safety events is very important because reporting is one of the most important things of a safety culture. And safety culture determines always how safe we can keep our patients and deliver care to them. I think this is known everywhere. I think everybody knows about it. Everybody is familiar about it. We still have communication failures in healthcare system, and communication failures are a cause 60 to 70%, maybe more percent of cases responsible for our fatal errors in healthcare. These are the issues which would demand that we establish a psychological safety within the organizations. What do I mean by this psychological safety? Is that staff, especially the frontline staff, the nurses, the resident staff, and the junior staff, should have the confidence to speak. Once they should feel psychologically safe to speak. They should not have a fear of retribution. They should not have a fear of actions. They should not have a fear of getting fired or getting reprimanded. And unless we give them this confidence of psychological safety, they may not be able to report their incidents and their problems. The other issue which I want to highlight here is the authority gradient. Authority gradient is a barrier which does not allow junior staff to question their seniors if they observe a possible breach in patient safety. I think this barrier needs to be either flattened or dismantled if we really want to achieve patient safety. This applies especially in areas of critical care, in ICU, in delivery suite, in operation theaters, where sometimes juniors observe something and they can't speak because they are scared of seniors, and usually the complication of a patient happens. Unfortunately, they can't speak. I have to tell you a small story about here. One day there was a labor going on in a delivery suite in one of the hospitals where I was working in Dubai. The patient was going into, there was fetal distress observed, and there was a clear evidence that fetal distress is going on, and the baby is in serious trouble. The nurse who was attending the doctor and the specialists has a lot of apprehension that something wrong might happen, but she was not able to speak because she was scared that she might be reprimanded by her seniors. And eventually what happened, we had a stillborn baby. And when we conducted the root cause analysis and we interviewed the staff, and we came to know that this nurse, when she was asked, what did you do when you saw the things happening? She said, I was scared to speak. So this is very important. Psychological safety and authority gradients need to be addressed by the leadership in the organization if we really want to improve patient safety culture. This is a very interesting story. It dates back to 2012. As you all can see, this is written that you are removing a wrong kidney. The surgeon this happened in Cardiff, in one of the hospitals in Cardiff. The surgeon was told by a resident staff, you can see, the surgeon removed the kidney, the healthy kidney of a patient, and he was left with a wrong kidney, with a diseased kidney, and which resulted in the death of the patient eventually. There was a surgeon, Dr. Mahesh Goyal, dismissed the concern of a resident and of a student, and passed on with the surgery. The student warned him and requested him that we are going to remove a healthy kidney, but his concern was dismissed. And here I mean to emphasize that although he talked about the student brought the attention of the surgeon, but the surgeon dismissed it. This is what we call as authority gradient. Dr. Goyal and the consultant John Roberts were accused of manslaughter over an appalling error which resulted, which left 70-year-old patient Graham with diseased kidney. And this went to the court, and eventually the court decided that it was really a gross negligence and a crime. So by showing this clip in detail, I want to emphasize to all my colleagues who are watching here, to all the participants, that we really need to listen. to the voice of the frontline staff. Sometimes they can see really what we can't see, and it's a teamwork. If somebody raises a concern, we should listen to it always. The concern may not always be right, but we should always listen to it. So this is a very profound example of one of the things where psychological safety and authority gradient have a role. Whether we should speak up or keep quiet is our own preference, but I am a strong advocate of the speaking up option, because unless we speak up about our problems, they will never be addressed, they can never be solved, and we can never be able to achieve patient safety in a real way. Unfortunately, I have another video about use of critical language in patient safety. Critical language is a tool. Let me go to the next slide. Let me expand here whatever I had to show in a video. Critical language is when we see that something wrong is happening, especially in areas of critical care. And when the staff feel that they are concerned, this is a cuss. This is a cuss. We call it cuss words. They say, I'm confused, I'm concerned. And then they feel uncomfortable that things are not going well. And they also think that this is a safety issue, that we need to stop the line. But it can only happen that if we have a safety culture and we have a psychological safety and there is no authority gradient. Otherwise, it is very difficult to use this cuss tool. I'm sorry I cannot show you the video because there was a lot of nice examples in my video, but I am sorry it happened, like I don't know, there's a technical glitch. I would like to share with you something else here, which is an incident ratio of Henry's triangle. You know, there are 3,000 unsafe acts or behaviors which happen within an organization. And these form the biggest percentage where we have a potential for causing an error. And subsequently after that, what happens, there are the 300 near misses. And we do very few investigations for these near misses because usually they may not be reported, and we don't pay really attention to them. And eventually what happens is we have got approximately 29 minor injuries, and most accident investigations are conducted here. And you can see the bottom of the pyramid. Bottom of the pyramid is what's very important, what we usually miss. And here we miss some things, then we really miss a near miss here, then there are injuries, and eventually there are adverse events or sentinel events. So we have to be very mindful when we are discussing patient safety culture or patient safety leadership walk-rounds about this thing. And another thing which we can detect at our patient safety leadership walk-rounds are, you know, we have got certain sharp and blunt ends of patient care. Sharp ends are where the care is actually delivered. They are called active errors. They are usually made in operation theaters, neonatology, labor suite, and emergency department, where real-time decisions are taken by the caregivers and our defenses fail. Blunt end happens, it is distal to the sharp end, and these things are usually dormant and they are sleeping for many years. We actually even don't know about what's happening, and they are dormant for many years. There are lack of policies, protocols, there's a lack of skill mix, there's a lack of supervision, there's a lack of staffing, there's a lack of orientation, there are maintenance issues. We usually call them blunt end of failures, but sometimes these blunt end can precipitate and they can lead to a sharp end and cause patient harm. And another thing which I want to bring to your attention is the error causation. This is sharp versus blunt end, and you can see the end is patient develops ARDS, We don't have proper transfer guidelines. There's the lack of supervision. The communication breakdown is always there. And there is an inadequate training and staff skill mix is there. Ventilation is not being properly handled because technique is not being trained well. And then there is inadequate patient monitoring because of lack of maybe clear policies and procedures or training, and eventually the patient gets ARDS. And this is how the accidents usually take place in our organizations. I am sure most of the audience and most of the watching my presentation are aware of this thing. This is what we will discuss at our leadership walk-rounds. We usually pick up the latent errors, system defects, what are the trigger factors, what are the unsafe acts, what the staff can do on an everyday basis. They actually resort to workarounds. They find an easy way of doing things and they really do it. And that breaks our defenses and that causes errors. Defenses are broken and an accident happens. The reason why I showed these few slides is to have an idea that why leadership walk-rounds are very important, to know about these things on the floor at the from the frontline staff. Unfortunately, I had another video about patient safety culture. I cannot show it because of some technical glitches. I apologize for that. And patient safety culture is very important because we should have a blame-free culture, non-punitive culture in the organization. And actually, through leadership walk-rounds, we will be able to understand whether our culture is a pathological culture, whether our culture is a non-punitive culture, or whether our culture is a learning culture or a growing culture. Though we have to, there are certain indicators where we determine whether the culture, what type of culture does an organization have. Because leadership walk-rounds have a very important effect in developing the patient safety culture, in developing the non-punitive culture, and developing a learning culture. Now, how do we actually start getting on about the leadership walk-rounds? We need to educate the leaders, actually. We need to educate the leaders about the concept of leadership walk-rounds. We need to have a scheduling process, and we need to be focused on scheduling process. It's a serious business, which all of us have to take very seriously, especially the leadership. Before we go to the walk-rounds session, we need to have a briefing session with the leadership in the committee room. All the leaders, senior leaders, sit down in the committee room and discuss the plan, which ward we have to go, which unit we have to go, and then we have to plan a set of questions to be asked from the frontline staff. And we usually have a clear plan before we go out. Then we go out to the floor, and after we complete our walk rounds, we come back to the briefing session with the leadership. We discuss what comments we got from the frontline staff. And then after that, there is a tracking of data. This is the most important function which we have, because usually what happens sometimes, these things get lost and we just focus on the discussion we had on the floor. But data collection is very important. And we have to report the comments, the findings, and eventually we have to go back to frontline staff with our with what we have done and what actions are being rolled out and what is the status of those actions. And measurements are done through data analysis and trending, and it's a process, it's a continuous process which has to keep going on. That's how we go usually with the group. The CEO is the leads the group, and then there are other senior leaders, director of nursing, head of departments, and all those leaders. We usually have an opening statement actually at the beginning of a walk round. And this opening statement is very important actually. What we actually, it generates a sense of confidence and trust among the frontline staff. We tell them that we are going to this organization, we are going to move these organizations towards an open communication and a blame-free, non-punitive environment. And this is going to help us to improve our patient safety. We emphasize to them that our questions will apply to your errors, communication failures, teamwork patterns, distractions, inefficiencies, duplications, and redundancies of work. And we also emphasize on them that we'll take this information from the conversations and we'll use them to improve your work and try to deliver better care to our patients. So opening statements usually delivered by the CEO and or the designee of the CEO, and it has to be, it's one of the important things with which we start our leadership work. How do we facilitate our walk rounds? We need to express commitment at all levels. Senior leadership, middle management should have a commitment to these walk rounds. And what we do actually, we observe the work of frontline staff at the frontline workstations. Sometimes we just go and only observe what they are doing without disturbing them. And then we have to ensure that we are very approachable to them, because this helps to create an environment of a safe environment in which they can speak up without fear. As I said at the beginning of my presentation, this is very important. We have to actually drive out the fear from the staff about speaking up. This is one problem still exists in healthcare organizations, in many healthcare organizations around the globe, that frontline staff are scared to speak up. So this is very important. And then once we talk to them, once we make ourselves approachable to them, we listen to them, we build up a trust. And once we develop our trust between the leadership and the frontline staff, then we have the questions. We usually ask them open-ended questions. And then this helps us to motivate the staff and generating the desired actions. So it's some sort of a bottom-up approach where we talk to the frontline staff, we get their opinion, we go back to the boardroom, we discuss how to put those comments into action, and then action plans come from the top down. I know of some of the organizations which are very lucky, where patients are really very lucky. They are actually, they involve the patients and their families also in the leadership WalkRounds. And what it does is actually it provides an opportunity to patients and families to voice their concerns and suggestions. And from my experience as a patient safety professional, as a risk manager, I have observed that patients really know a lot about their care, what's happening to them, what possibly they feel is going wrong. And talking to them and getting them involved with these rounds would be a great opportunity for us to improve patient care. Who participates on these walk rounds? You can see all the leaders are there, starting from the chief executive officer, director of medical affairs has to be there. And then there are various directors of nursing, administration, and service and support services, heads of the department where we go. The concerned head of the department has to be there because their presence is very important. Then director of quality and patient safety and risk manager or a patient safety officer has to be there. And sometimes if we need, we call the representatives from the pharmacy, the laboratory, the radiology, if their presence is necessary for linking them to patient safety issues. There is a secretary who documents the findings. and they eventually put it in the leadership database, and that's how the reports are generated. How do we schedule the walk rounds is depends upon the policies of the organization. And in my experience, we used to do it actually twice a month. And then every month, once the rhythm would settle down, usually we used to conduct them in the mornings and sometimes in the afternoons. We used to go to the emergency department, usually in the afternoons. Otherwise, we would visit the other facilities in the morning. And all the facilities we used to go, emergency department, laboratory, radiology, even operation rooms we used to go and sometimes silently watch what's going on out there. And then it needs what Leadership WalkRounds does, that it generates a structured conversation with frontline staff. It could be in a corridor, it could be in a department, it could be in a unit, it could be at the entrance of the hospital. It could be anywhere practically. What concerns are usually raised during these walk rounds? It could be any concern basically. As some staff have individual concerns about safety, about the ratio of staffing, about their shift problems, and it could be whole system concerns or unit concerns that would cover the equipment problems, that could cover the training issues, and environmental concerns of noise. Then there are sometimes issues with variation in patient care processes, and sometimes we pick up education and training gaps if staff need some trainings, orientation gaps. And we usually discuss perceptions about patient safety culture. This is a very key issue during walk rounds. We need to understand from the staff whether they really have a clear concept of patient safety culture, and how much is their knowledge of it, how much is put into the action. And then we also discuss with them their support levels from supervisors and managers of the departments. And now we come to the certain questions. This is a tricky affair. Now, we ask them usually, how can the next patient be harmed in your area? What do you think? Do you have a very clear policy for handoff, for example? Are you handing over patients in accordance with the policy of handoffs? When was the last patient harmed in this area? And what happened to the patient who got harmed? Did the patient have a near miss? Was the patient returned to OR? Did the physician attend the patient in time? And also we ask them what prevents you from keeping your patient safe. Sometimes we even ask them, do you feel your son, your daughter, or your brother, or your sisters, or your parents, you could admit them to this floor? Although this is an emotional question, sometimes we used to ask them. This would generate a very important conversation, whether they would really feel safe in the floor. And we also asked them, did we think of any events in the last few days? Was there a morbidity or a mortality in your unit? And also we asked them, how can senior leadership ensure patient safety is achieved? This is very important. We want to show them that degree of empathy and sympathy, and to make them feel that we are there to listen to them. It's their chance, it's their time to speak up. We should allow them to speak up more, and we are mainly going to observe what they are speaking and listen to their concerns, document them, take them back to the boardroom, discuss them, and develop strategies to help them. And some of the questions are surrounding the teamwork. Do you have a proper teamwork approach within your unit? Are your staff or your other colleagues cooperate you whenever it comes to doing things as a team? And do you always report errors? That's also very important. If an error happens here or a near miss happens, do you report it? And if you don't report it, why don't you report it? It's just to be asked. And next is a very controversial subject. How is, we usually ask from the nurses, how is your communication with the physicians? And do you raise your concerns with the physicians, especially for hand washing? And this is very important. We do ask them sometimes. And at the end of the question session, we, the CEO or the designee, we extend them a word of thanks for participating on this WalkRounds. We read out a statement saying that our job is to take information we have given you, you have given us, we analyze it carefully, we plan actions to fix your problems, and we will assign responsibilities to individuals till the problems are resolved. And we emphasize to them that we promise you that we will let you know what have we done with your suggestions, and we will come back to you and see that those comments were addressed and completed by the concerned responsible. And after the walk-rounds, we usually again go to the meeting room and we discuss that. We have a debriefing session in which we discuss, we analyze what we discussed, and we prioritize, and we identify issues to be sorted out. And then debriefing information is provided by the risk manager to the executive leadership. And we always send a note of thanks to the staff who participate in our leadership walk-rounds. This is very important. We have to appreciate them, and we have to thank them. Data collection, we have to track the comments of the staff who participated, and we have to document them. There is a leadership, there's a walk-around database in which all the findings are logged in. Feedbacks are sought from the departments or units wherever we went. And we have to have very clear set of time frames for getting the actions done and closing the loop. And walk-around reports are submitted to the CEO and the directors. And when we revisit the areas next time, during the next walk-rounds, we review the action, we review the status of the implementation, whether the action has been started, it's ongoing or completed. These are some of the measures of examples of measures of success we usually track. Structure measures, process measures, and outcome measures. Among the structure measures are number of patient safety changes initiated by the managers per year. That would involve whether the staffing ratio was improved, whether the training has been improved, or it would involve a process measure whereby we will see the number of errors reported per month. The incident reporting system is going down or going up or staying the same. And then there are sometimes certain outcome measures where we have changes in the percentage of rates of infection rates are staying the same, or there's a change. Are they improving? Are they deteriorating? And what about the readmission rates? And also we monitor the patient satisfaction rates and see these are certain measures which we track as a part of our leadership walk-rounds. What we can achieve by doing this exercise of walk-rounds, we can improve the communications between the frontline and senior leadership. This is an ongoing dialogue between caregivers and leaders. And this is one important point is that we encourage the staff that we will be adopting a non-punitive approach for reporting of near misses and safety events. This is one important thing which we have to emphasize and re-emphasize, that there will be no punishment for anybody reporting a near miss or a safety event. And then during these walk-arounds, we usually study the level of knowledge various frontline staff have about patient safety and quality. And we usually pick them up as patient safety champions. We train them. There's a format for training, and we assign them as patient safety champions. Some example of certain actions taken at the walk-rounds immediately are, for example, we observed some of the units observed that there were revised early warning signs score. Revised early warning score charts are not being used by the staff. And when we asked why they are not being used, the answer was we had a large number of old stocks issued by the supplies department. Administrative director immediately instructs the supply staff to remove all the old charts from the circulation. So matters resolved on spot. Nursing staff are facing negative behaviors from a small group of physicians about hand hygiene compliance. This is not an uncommon problem. We all face it everywhere. And now it's improved after, I hope this is a big improvement after this COVID-19 problem, hopefully, and God willing. Medical director issues a circular for adopting a zero tolerance approach to address this non-compliance. Note, zero tolerance. Anybody who breaches this hand washing compliance has to have, we need to have action against that. For example, medication errors are increasing in one of the clinical departments. The CEO instructs the pharmacy and risk manager to establish a system of competency testing right at the spot. So what we usually observed at the rounds, that physicians, especially the newly recruited physicians, are not familiar with e-prescribing medication. So once they are trained and we do a competency testing, they could be better and our medication errors could come down. Now, data analysis is according to a severity code. We call it severity assessment code, and there is a Vincent Taxonomy for that. I'll come to it later. And this is the safety assessment code, where we see about the frequency, how frequent it is, whether it's frequent, it's occasional, it's uncommon or remote, whether the effect is minor, moderate, major, catastrophic. This is a risk assessment. This is from a risk assessment perspective, and usually when we have the findings, when we have the comments from the frontline staff, when we take the comments back to the boardroom, back to the database, we usually work it out like this. And also this the data is usually logged as per this this taxonomy, whether the issues are organizational, including structure, policies, standards, culture, whether they are related to environment, supply, staffing, education and training, teamwork issues. These are separated. And then there are individual concerns about competency, skills, physician, mental stress, and all those things. And there is a burnout issue. We picked up sometimes we picked up issues of a potential burnout, where usually the nurses and junior residents were so much stressed out that they were about to have a burnout, and they were identified for help, and we got them help actually. And then there are patients about their complexity, language, social risks, and treatment risks. All these things are actually categorized and they are logged in the leadership WalkRound. Feedback loop is comments sent to the managers with suggested actions. Actions have to be suggested by a group of leaders in discussion with each other. And then we have a monthly summary to manager, director with timelines for tasks. And then eventually the quarterly summary is sent to leadership with the status. Action rolled out, ongoing, completed, and the results. What are the targeted results which we have? The targeted results are, for example, what percentage number of comments and planned actions we captured, percentage of actions completed and closed, a number of quality improvement projects which were planned and which are underway to improve the quality and patient safety, and number of adverse events and near misses reports which came in the incident reporting system after we launched the Leadership WalkRounds. And eventually we have a patient safety survey culture in which we find out the rates of teamwork and interest in patient safety are the same, or they are improving. And usually as a result of Leadership WalkRounds, there is an evidence from the literature that all the parameters which I have shown you, the results, targeted results are achieved. Actions are usually completed because there is no escape for the middle management. Once the senior leadership knows that there are issues on the floor and they have been picked up, the middle management has to work on it and get it done. And percentage of actions completed has to be monitored because leadership is monitoring the reports. And quality improvement projects have to be launched because there are certain issues where we have a quality improvement project. They need a project and they have to be done, and they are monitored by the leadership. And of course, the reporting, I have personal experience. In my personal experience, I have noticed reporting of adverse events and near misses has improved a lot after WalkRounds. Why it improved a lot? Because we were able to achieve psychological safety, and we are able to some extent also address the authority gradient. Now, these are some of the references which have been used while compiling my presentation. They are already on the presentation. You can have a look. And I would welcome any questions, any suggestions. And really, I apologize to the audience, to my colleagues, to speakers, and to the participants that unfortunately, because of some technical glitch, you were not able to see my videos. My sincere apologies for that. And thank you so much.
Dr. Farook, thank you very much. How long do you think one of the videos will take? Because we've got about, let's say, 7 minutes or so. Is it longer than 7 minutes? And we can try again.
Actually, the most important video would be to show the first and the last. We can skip over.
And how long?
It's
how
3
long
minutes
is it?
each. 3 minutes.
Sorry?
3 minutes.
3 minutes.
Yeah.
But can we try it without your earphones on?
Okay, no problem.
Can you unplug and then maybe try the first one, or the one that you say is the most important? Dr. Farook? Dr. Farook? Can you also unplug your earphones from the system? From the system. Unplug from the laptop, wherever.
Hello?
What I was saying, unplug the earphones also from the system.
Okay. I'm sorry. Okay.
Okay.
We do executive walk rounds, so safety walk rounds on a regular basis where we go out individually through and we talk to staff, we talk to patients and families.
You must share with us. We only hear the audio, not the video. We can't see the video. Share the audio.
What's working well. We learn a lot from that experience.
WalkRounds are being done probably in 400 to 500 organizations in the United States at this point. You really want to get leadership carrying the banner of patient safety as a way of promoting the idea in the organizations, something which good leadership should do but hasn't necessarily done very effectively in our healthcare organizations. But then get to ask them specific questions around issues of patient safety.
And we ask people very bluntly, has there been an occasion during the last few days where you worried that you put a patient in harm's way? Have you made any errors? Have there been some near misses?
Right now, one of the things that we work on are something quite simple. It's called a safety briefing. That begins at the start of the day when nurses change shift. So they share with one another their perceptions of what's going on that day in the unit. So they might highlight that we have a new piece of equipment, we have a patient on a new drug protocol we're unfamiliar with. Mrs. Jones in room 3 has a high fall risk. And by the way, you've got a new graduate who's pretty green and unfamiliar with what's happening. So you get a sense of what the environment is you're working in today. And you already have a different sense of risk and alert. And you can direct your care in a very different way than you might have otherwise.
It works, it really works. We see teamwork and multidisciplinary rounding and huddles cut error rates promptly.
Patient safety culture is something which must be put into context of the larger organization. If you go in and look at the culture of a hospital or a healthcare system, if the culture is good about all domains of what it does, it will be good in safety. Safety is a particularly unique area of emphasis and focus that we must have. We must be passionate and clearly paying attention to it.
Patient safety is only one of a variety of issues that our leaders are engaged with. And many of them don't feel responsible for the safety and quality of care. The traditional division of responsibility puts the management of the system responsible for the finances and the physical plant, and the clinical leaders, primarily the physicians, in charge of the delivery of care. The question is, who is responsible?
Failing because now we just hear the audio but don't see the video. We'll share it later then so that we can give the next speaker the opportunity to present. But I must thank you for a very informative presentation. It was really very, very, very helpful, and the way you are doing things, and I'm sure the main aim is patient safety, and with all the inputs that you guys are doing, whatever you're doing on those walkabout rounds, I hope you get 100% patient safety results from this intervention. Thank you so much.